So today we're going to just kind of dive into fetal echocardiography. And this is actually, these notes are from a previous book. However, over the years, I have just kind of tweaked it to what I really want you guys to know. So instead of like really, I would love for you to read your chapters 35 and 36. But sometimes it goes into such detail that I feel like you can get overwhelmed. And for this OBGYN class, um, I feel like you need to know the basics instead of getting so overwhelmed. And so there's just so much that you don't need to know just starting off. So I've kind of skimmed throughout the years and put together slides of what I feel like you should know um, to get you started and to get you doing complete ultrasounds. We know all about the circulation um, through the baby. We've talked about it with multiple different chapters. So I just feel like you can just read this and kind of get your remember it from previous chapters when you've had to even tell me about it. Um, this is a really good like little diagram that I really like of how the blood is shunted to different things. The placenta, the umbilical vein, how the ductus venosus shunts it from the liver, the right atrium, how the foramen ovale shunts some of it to the left atrium, and how the ductus arteriosus also shunts some of the blood. And so those are your three main openings within the fetus: the ductus arteriosus, the ductus venosus, and the foramen ovale. Those close after the baby is born. So when you're doing a sonographic evaluation of the heart, you're going to, and I have put my other cardiac notes on here, and we talked about the 4-chamber heart. And the 4-chamber heart is the minimum view. You can see a lot of different cardiac anomalies from the 4-chamber heart, but you definitely can't see all of them. And one of the big ones that you can't see is transposition of the great arteries, which we'll talk about. And so that's why it's important to include the outflow tracts on your 4-chamber heart assessment, like on your heart assessment. Some places will include also the aortic arch and the ductal arch and the great vessels. So I will kind of talk about those too, so you're aware. So here's our 4-chamber heart. You can see all 4 chambers. The one closest to the chest wall is the right ventricle, the left ventricle, right atrium, and left atrium. So the right atrium and left atria should be equal in size, which in this image it does looks like they are. The left atria is closest to the spine, so that might be another landmark for you to be able to distinguish that. The right and left ventricle should be equal in size. The right tends to be larger, although sometimes it doesn't give that appearance because the moderator band, which is in kind of the apical portion of the right ventricle, kind of can make it look not as large. But usually, especially in the 3rd trimester, the right ventricle is larger, and that's because of the pulmonary artery and ductus arteriosus pushing that blood through the heart. And the left ventricle is more smooth shaped and conical. You'll see the interventricular septum and the interatrial septum with the whole of the foramen ovale. And then the mitral valve and the tricuspid valve. The tricuspid valve is more apically located. There's a couple different ways, and when we get into doing scans, it'll make a little bit more sense. But there's different views of seeing the heart depending on how the baby is laying. If the baby is laying more spine up, you'll get more of an apical view. If the baby is laying kind of on the side, you'll get more of a subcostal view. Either one is okay for evaluating the heart. I feel like the subcostal view, you can see the ventricular septum better. And while the apical view, sometimes you'll get a dropout on the ventricle septum that will look like a hole, but it's actually just dropout from the ultrasound beam waves. Here's another image here. So this is a baby who is breech laying on the right side. So the left is up. The right ventricle is closest to the chest wall, right atrium. Left atrium is closest to the hole right here, which is the aorta, and then this is the left ventricle. Let me see if I can start my scans. Sorry, technical difficulty. I might have to see if I can get it. Here we go. Okay, so this sonographer starts at the stomach, then goes to the 4-chamber heart here. You can see all 4 chambers, right ventricle, left ventricle, right atrium, left atrium. So then you're going to go up more superior, open up the left ventricle, LVOT right here. This baby's moving all around like crazy too, which makes it more difficult. But so that's the LVOT. So that's your 5th chamber view. And then from there, you're going to go up just a little bit more superior. And right here, this little flapping right there is the aortic valve. And then as the sonographer goes up even more superior, the pulmonary artery comes in. You can see the divide here. That is the 2 pulmonary arteries. And then lastly is the 3-vessel view as you go into the neck. Pulmonary artery, aorta, and SVC. And that's how you would do a normal scan, just a quick scan through. So what we saw on that cine clip was the 5th chamber view with the left ventricle, the LVOT coming out of the left ventricle here. This is called the 5th chamber view. This is showing the pulmonary artery right here. This is going to be the right ventricle outflow tract. You can see how it divides at the bottom. Those are the 2 divisions of the left and right pulmonary arteries. You also want to include a diaphragm picture with the stomach below, and you guys know why, because we're wanting to rule out a diaphragmatic hernia. This is the aorta. Look how beautiful that is. It has the candy cane shape that we talked about in previous lectures. And then you have your 3 branches. This is with the spine on top, and this is with the spine on bottom. Both are sagittal views of the heart. All right. Let's watch it. So the sonographer is going to look for the aortic arch. We want to see it going in from the middle of the heart. So the aorta comes out of the middle of the heart instead of the anterior portion of the heart. It's just showing the arches again. Next up is the ductal arch. The ductal arch is the pulmonary artery connecting to the ductus arteriosus going to the descending aorta. And it looks more like a hockey stick, and it comes off the anterior portion of the heart instead of the middle of the heart like the aorta. This again is in the sagittal view of the heart. They have a very close relationship, especially when you see them in a 3-vessel view. It's the pulmonary artery, the aorta, and the SVC. So this is the 3-vessel view. So from the 4-chamber heart, you go up superior, and you're going to see the pulmonary artery. You see the divisions of the pulmonary artery. The next circle is the aorta. And this last circle here is that SVC. One of our students, mnemonic was PASS, pulmonary artery, aorta, and SVC. So it's a good way to remember it. You can also do color Doppler, and you need to do color Doppler with your images. A lot of your places where you're going to go have split screens, so you can do a 2D image on one and a spectral Doppler on the other, and that's really a great way to evaluate the heart. There's even 3D of the heart, which is really cool. What we're looking at here is the crisscross pattern of the aorta and the pulmonary artery. Seeing that crisscross rolls out a lot of the congenital heart defects. So the aorta is on behind and the pulmonary artery is on top, and that's how we do want to see it. You can also do left ventricular volumes when you're doing 3D. Now, at our facility, we don't do 3D, but I know sometimes at the higher centers, they might if they're looking for a specific kind of anomaly. Okay, so we want to also take an M mode of the aorta or of the heart. This one's at the aortic root. I like for you to put the M mode tracing or the M mode cursor within the ventricle, and that will give you a good heart rate. And you measure depending on how your machine's set up. This is set up on a 1 cycle. The machine at your school is set up on a 2 cycle. So you'll measure from one hump to another hump here, and that will give you a heart rate. Now, if you remember, 120 to 160 is what we want the heart rate to mostly be. If it's greater than 160, it's called tachycardia. And of course, the baby is going to get excited and move around. And if it goes up and has some elevation, that's great. But we do want it to get down. And especially if it's greater than 180, I would call it a tachycardia. On the same opposite side, less than 120, we have decided is bradycardia, especially less than 110. Some people in the 3rd trimester feel like 110 is okay for a heart rate, but I usually get nervous if it's less than 120. So those are kind of your parameters for a normal heart rate. You will sometimes see arrhythmias. Arrhythmias are just like skips of beats. Sometimes they can be premature atrial contractions. Those are the most common. Sometimes they can be PVCs, which are premature ventricular contractions. They're pretty easy to pick up. So here is our, again, greater than 180 is tachycardia, less than 100 is bradycardia. 100 to 120 though, I definitely would mention on your report. I would not let a patient leave in the 2nd, 3rd trimester if the baby's heart rate was 101. I would definitely be calling the doctor because they will want, that's just too low, I feel like. So premature atrial contractions, they can be easily identified on M mode, and they also can just be easily identified when you're just doing a cine clip through the heart. You'll see an extra contraction of the atria outside the ventricles. So here's the atrial. You'll put the M mode where the atria are, and it'll be like boop, 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 and then an extra beat right here. This is SVT. So this is supraventricular tachycardia. And this is really scary when you see this. The heart is just flying, 303 beats per minute on this one. And it's scary. It's scary. And if a baby is undiagnosed with SVT, the baby can develop congestive heart failure and also go into heart failure and have high drops. So let me show you this if I can.
This is a normal sweep through the fetal heart with normal anatomy, but with an obviously fast heart rate of 260 beats per minute, which is consistent with supraventricular tachycardia. Note that there is no high drops and yet this is a persistent tachycardia. All the structures of the heart are well seen, just moving too fast. Now looking at the abdomen, we can use the abdomen to look at the ductus venosus, which you'll notice is completely reversed in the A wave. Using the M mode is a good way to time, and using the MCA is a good way of looking at the heart function.
All righty. This is a premature atrial contraction. Oh, did you see it? Oh, there it is again. Oh. Oh, see it do that? That's a premature atrial contraction. So that's an arrhythmia. Okay, so there's different congenital heart defects. This is how you want the heart to look like. The SVC and the IVC going into the right atrium to right ventricle up to the pulmonary artery. Some blood goes through to the lungs, others shunted from the pulmonary artery to the ductus arteriosus, where it goes to systemic and circulation. Some blood goes to the left ventricle up to the LVOT to the aorta to systemic circulation. Now, these are different things that can happen, and all at VSDs, holes in the heart, constrictions. Man, there's just a lot of stuff. Transposition of the great arteries, switching of the different, huge VSD, pulmonary atresia. I mean, there's just so many just different congenital anomalies that you can get overwhelmed, especially when you're just learning how to identify a 4-chamber heart. So I'm just going to go through the most common. The first one that you probably heard about the most is a VSD, which is like a separation in the ventricular septal defect. Now, a lot of these just are isolated. Others are just, they're from another kind of congenital anomaly that the heart has had to make a VSD to shunt the blood. So isolated VSD are the most common cardiac malformations, accounting for approximately 30% of the cardiac abnormalities. Membranous, perimembranous are the most common. The 4-chamber heart is utilized for prenatal diagnosis of VSD. So you can see here, there's a big hole in the heart there with the blood shunting. Here's another little one right here. Here's a video. These make me nervous, the subaortic VSDs, because they're very, very difficult to diagnose. The best way to diagnose it is in a 5th chamber view where you're looking at the LVOT. Looks like right there, there's a VSD. Right there, this little hole. Those are so difficult to see. A lot of them aren't caught in utero because they're difficult. Let's see if we can, oh, I saw it right there. There's just, you want to see this VSD intact, or you want to see this interventricular septum intact. And when there's a hole in the middle, it shows it, but it takes time to learn how to do those. Hey, a C-cam, we've talked about that before. This looks like bigger cyst, so this is probably type 1 C-cam, and that can push over a heart to the right or left side, so dextrocardia or levocardia. So there's also a thing called an atrial septal defect. Now, atrial septal defect are difficult to diagnose because the foramen ovale is there. So the foramen ovale is supposed to be there. So there is a hole in the atrial septal. But if you see an extra big hole, or you're not seeing part of the ostium primum that you want to see, then there could be an atrial septal defect. Let's see. An atrial ventricular septal defect is where, well, a lot of the times it can encompasses a range of cardiac malformations involving combination malformations. AVSD is most common in trisomy 21. It's also called endocardial cushion defect. And sometimes it's just when there's a huge hole in the heart that's involving both the atrial and the ventricle septum. They're pretty easy to see on subcostal and apical views, and they appear as a large anechoic area encompassing the lower portion of the atrial septum and the upper portion of the ventricle septum. So there's just a hole, in a normal 4-chamber heart, you'll see this ventricle septum extend all the way up here to the ostium primum of the atrial septum, and here it's just a big hole. Here's a better one. You can see there's just a huge hole in the middle of the heart. Most of these have a chromosomal abnormality too. Well, come on. It's been a while since I pulled these up, so maybe they're just taking a while. All right, here it is. So you can see where the atria should be, there isn't one. It just looks like a big hole. And so even the leaflets look like there's just 4 leaflets on. It's difficult to even see like a mitral and tricuspid valve. Hypoplastic left heart is the next thing you're going to see. And it's pretty sad. It's where there's an underdeveloped left heart. A lot of the time, there are surgeries for these babies now, which is great. The survival rate is getting better. But it is kind of one of those more serious heart defects. So the right side of the heart is going to be pretty big, and the left side is going to be very small. It's the most severe left-sided obstructive lesion. The basic components of hypoplastic left heart include a hypoplastic left ventricle, aortic atrasia, hypoplasia of the ascending aorta, mitral valve atrasia, and hypoplasia, in some cases, a small left atrium. I'm hoping that they zoom up on this. Sometimes it only looks like a monoventricle, if that makes sense, because the left ventricle is so small that the right ventricle and right atrium kind of just take it over. And so it just looks like a single atria and ventricle. And anytime that I really see that, the first thing I think about is hypoplastic left heart. Again, hypoplastic left heart is associated with a lot of the congenital anomalies too. Right ventricle hypoplasia doesn't happen as often as left, but it's kind of the same thing. It's going to be a small right side of the heart, and it's extremely uncommon. Generally results from pulmonary atrasia. So what I want you to know about pulmonary atrasia, it's extremely uncommon, usually results from right ventricle hypoplasia results from pulmonary atrasia. But if you see like a small right side of the heart, that's probably what's going on. You can see a patent tricuspid valve. So the tricuspid valve is still working. And if you see a small pulmonary artery with absence flow, that kind of hints it off there. The baby will probably have developed a large VSD to shunt the blood from the right to the left side. So this is a image of tricuspid atrasia, which I think seems to be a little bit more common than right ventricle hypoplasia. But basically that means that the tricuspid valve is not working correctly. So what's going to occur is, because these little fetal hearts just kind of adapt in utero, because they use their shunting ability, that AST, atrial septal defect of the Freeman Valley, is going to shunt the blood through the left atrium to the left ventricle, use a VSD to get it to the right ventricle and then out to the pulmonary artery. So it's pretty amazing. So presence of the VSD may be preserve some of the right ventricle development. Sonographically appears as a hypoechoic thickened valve. So you'll just see that valve just not working correctly. It'll just not be flapping. It'll just be hanging out. Next thing we're going to talk about is coarctation. And coarctation is basically narrowing of the aorta. Sometimes it's very difficult to diagnose in utero. It can be in different spots. It could be pre-ductal, at the ductal, or post-ductal. So it refers to the narrowing of the aorta along the aortic arch, resulting in outflow obstruction with a degree of obstruction related to the degree of narrowing that occurs. Described as preductal, ductal, or postductal, difficult to diagnose prenatally, and diagnosis of interrupted aortic arch is more obvious. Now, interrupted aortic arch. See, here's a little narrowing in the aorta there. So interruption of the aortic arch is basically where the aorta just stops developing, which is crazy when you kind of think about it. So that's a lot more obvious. Here's an image of that: the right atrium, right ventricle, left atrium. So what happens is, because these hearts, like just how they adapt, it's crazy. The ductus arteriosus is able to shunt the blood from the heart to the rest of the aorta, the descending aorta. Although there is an area where the aorta is basically just not there. Tetralogy of Fallot is probably one of the most common congenital heart defects that we see. And it's the most common form of cyanotic heart disease. There's 4 classic features that I want you to know. Paramembranous VSD, overriding aorta, pulmonary stenosis, and right ventricle hypertrophy. So they will have a VSD. They'll have a very large aorta because the pulmonary artery is going to be stenosed. And later on, they'll probably have hypertrophy of the right ventricle because it's having to push so much blood. Here's a good image of that. So here's your hypertrophy of the right ventricle, a large VSD, stenosis of the pulmonary artery, and the aorta becomes larger and overrides the pulmonary artery because it's having to take more blood because of the stenosis. Tetralogy of Fallot is seen in chromosomal abnormalities. I feel like I've seen it in trisomy 18 and trisomy 21. I think even trisomy 13. Sometimes it just looks like a mess and I can't quite figure out what's going on. And then they're like, oh, it's tetralogy of Fallot. I'm like, okay. All I see is a big VSD and a big aorta.
Tetralogy of Fallot occurs in about 1 out of every 5,000 newborns. It affects males and females equally. Tetralogy of Fallot involves 4 defects postnatally: a large ventricular septal defect that straddles the overriding aorta, pulmonary artery stenosis, and right ventricular hypertrophy. However, in the fetus, the right ventricular hypertrophy may not be evident. For this reason, the 4-chamber view of the fetal heart may appear to be normal. Prenatally, a dilated aorta that straddles a ventricular septal defect is the most common finding. The pulmonary artery may be normal, small, or enlarged, the latter occurring with an absent pulmonary valve. This is the 4-chamber view from a fetus with tetralogy of Fallot. Notice that the 4-chamber view appears to be normal with no evidence of a ventricular septal defect. While disproportion between the right and left atrial and ventricular chambers is often associated with an outflow tract abnormality, when tetralogy of Fallot is present, the 4-chamber view is almost always normal. This is why tetralogy of Fallot is not detected when only the 4-chamber view is examined. This is a cine loop of the 4-chamber view. Notice there is no evidence of a hypertrophied right ventricular wall or ventricular septal defect. This is the 5-chamber view that is obtained in the transverse plane just cephalad to the 4-chamber view. Notice that the dilated aorta overrides the ventricular septal defect. In the majority of fetuses with tetralogy of Fallot, one of the first clues that this defect is present is the detection of an enlarged aorta. This is a cine loop demonstrating the dilated aorta overriding the interventricular septum where the ventricular septal defect is located. This view is obtained in the transverse plane just cephalad to the 4-chamber and 5-chamber views previously described. This is the 3-vessel view, which demonstrates the small pulmonary artery lying perpendicular to the large aorta seen in cross-section. The superior vena cava is also observed in cross-section adjacent to the aorta. This skinny clip illustrates the dilated aorta with a smaller pulmonary artery lying beneath it.
All right. Again, you just need to be aware. It'll come easier to you. Don't get scared. Ebstein's anomaly. Ebstein's anomaly is basically when the tricuspid valve is pushed down into the right ventricle. So the posterior and septal tricuspid valve leaflets are apically displaced from the normal location at the AV junction. So the tricuspid valve is not in the right spot, and it results in a very, very large right atrium and a small right ventricle. So you can see here, this is abnormal. The right atrium is this large area here. You can see that it's much bigger than the left atrium. So this is the mitral valve, and then this is the tricuspid valve all the way down in the apex of the right ventricle. These babies don't do very well. So the last one I want, well, okay, sorry, I lied. There's a couple more things, but one of the ones I really want you guys to pay attention to is transposition of the great arteries. I have seen this like 6 times this year. And it can be easily missed because you can't really see it in the 4-chamber view. However, as you look at the outflow tracts, you will see that they are flip-flopped, basically. So transposition of the great arteries can be divided into complete transposition or congenitally corrected transposition. In both conditions, the pulmonary artery arises from the left ventricle and the aorta arises from the right ventricle. So as you remember from our other things, this is flipped. In detransposition, the connection between the atria and ventricle are concordant, which means the right atrium is with the right ventricle and the left atrium is the left ventricle. And this is the one that we mostly see. And this results in parallel circulation. The aorta comes off the pulmonary artery, which causes deoxygenated blood to circulate systemically in the pulmonary off the left ventricle. The key to diagnosis of the complete TGA is the correct chamber identification. The 4-chamber view appears normal. So if you were just doing a 4-chamber view, you would not catch this. You visualize the outflow tracts and they appear parallel instead of crossing. So here is what I've seen like 6 times this year. I can't believe how many times I've seen it. It's crazy. So the right ventricle, the aorta is coming off there, and the left ventricle, the pulmonary artery is coming off there. So they're going to be parallel instead of crisscrossed. There's the 4-chamber view. It looks normal. So let me see here. I'm going to redo that. Okay, so here is the 4-chamber view. Let me get it back. So I can see, I'm trying to get it back to the exact spot. So this is our right ventricle and this is our left ventricle. The aorta is on the left side. This one's closest to the chest wall. The pulmonary artery is coming off the left ventricle, and the aorta is coming off the right ventricle. So they're more parallel instead of crisscrossed. L transposition is a little bit different. The ventricles are flip-flop with the atriums, and that actually, when that happens, it results in the correct kind of circulation throughout the body, but they will have a VSD. Truncus arteriosus occurs early on in embryology when the great arteries are dividing and they don't divide correctly. So instead of a aorta and pulmonary artery, you get a large vessel called a truncus arteriosus. Now, I haven't seen this for a long time. It's very rare. So a single great vessel is arising just above the interventricular septum. A VSD is uniformly present within the upper portions of the septum, just below the location of the truncus. And the truncus receives blood from both the right and left ventricles and perfuses the pulmonary, systemic, and coronary systems. So that's what that looks like. Instead of having your two separate great vessels, you have one big, large one. What? Sorry. Oh my gosh, what's happening? I guess we'll go back to our thing after this. There's the 4-chamber heart. Hey, it looks normal, right? So if you're just doing the 4-chamber heart, you're going to miss it. Oh, but there's a large vessel that is connecting both of them. Now I got to get back to my PowerPoint. Goodness. Double outlet right ventricle encompasses a group of disorders in which more than 50% of both the aortic root and the pulmonary artery arise from the right ventricle. So it looks like both outflow tracts are coming from the right ventricle. Here's some images of this. You don't have to be a thoracic surgeon and know all of these. You just need to know what it is. So this is a really great picture. This is how it should be. This is how it is. So for some reason, the aorta and the pulmonary artery developed more onto the right ventricle, which means that we need to have a big VSD to make sure the oxygenated blood is getting through the baby. A rhabdomyoma is a tumor within the heart. They're very easily recognized here as a large tumor. It's the most common prenatally diagnosed tumor. Echogenic mass within the right or left ventricle, 60 to 80% also diagnosed with tuberous sclerosis, and can result in arrhythmias, SVT, and high drops. What in the world? You guys, if we can't see it, it's not that big of a, okay, there we go. Here's a big old mass, and you can't miss it. You can't miss it, but you need to know what it is, and it's most likely a rhabdomyoma. Okay, so for our summary, you guys have hung with me, and I just really appreciate it because I love the heart. I got fetal echo certified 3 or 4 years ago when I started doing fetal echoes with a ped cardiologist, and I think it's my favorite thing to do out of all the ultrasounds I've ever done. I think fetal heart is, but I know it's difficult, especially when you're starting out, but I just want to tell you that if you stick with it, I feel like it's something interesting and you'll always be learning, and it's always challenging. And we have a little saying, me and couple of our cardiologists, no fetus will beat us. And that's what I want you to think to yourself when you're struggling with a baby that is just moving around, you can't quite get it. Say to yourself your mantra, no fetus will beat us. So in summary, the heart begins beating at 3 weeks post-conception. CHD is the most common malformation, congenital heart disease. The normal heart is at a 45-degree angle to the left of midline. Fetal arrhythmia may lead to hydrops. And that's it for today. We'll see you later, guys.